with the Heart of Medicine, and we're just I just wrapped up some questions, and I just want to share with you the pearls I learned from them because you might potentially benefit in your own studying, and you can maybe listen to this video while you're washing the dishes or walking your dog. So yeah, let me know your thoughts. So let's specifically go into the pearls, clinical pearls for the internal medicine ABIM certification exam. So in summary, this is going to be internal medicine. So this first question I got incorrect. They were presenting me a patient with peripheral neuropathy. They gave me the patient's labs, they gave me a CBC, they gave me a BMP, and they were basically asking me what is the following test most likely to establish a diagnosis in the patient. So these were the options. So one was lumbar puncture, Lyme disease serology, MRI of the brain and spine, serum immunofixation electrophoresis, and urine and blood for porphyrins. So the correct answer actually was one of the ones I marked out as incorrect initially, because when I read this question, I thought, this I wasn't actually thinking peripheral neuropathy. I was thinking more like this patient was having a subacute combined degeneration of the spinal cord, so i.e. vitamin B12 deficiency. And that was mainly because I was reading that the question said a reduction in pain and temperature sensation, vibration, and proprioception in the lower and upper extremities. So it wasn't only the dorsal columns, it was that was B12 deficiency. The patient was anemic, but the MCV was not elevated, so I was just assuming. And I just needed to latch on to something that explained that diagnosis to me in the question, in the option section. But to be honest, I wasn't sure of what was going on. Actually, what was going on was a peripheral neuropathy. So what they were asking is, how do you work up a peripheral neuropathy? So I did skip an important lab, which was the calcium. So this patient's calcium was 10.9. I just passed by it. It didn't register in my mind as being elevated. So this patient had peripheral neuropathy with a high calcium level. So what you should be thinking when you hear this is probably paraproteinemia, meaning that the elevated IgG, IgA in multiple myeloma might be producing this, and you want a serum immunofixation electrophoresis. So that was the right answer. So remember that in peripheral neuropathy, what you want to do, the main investigations, as long as you don't have a clear cause, right? Because you know that if you have a uncontrolled diabetic and they have neuropathy, well, probably you don't have to work them up that much. But if it's not clear enough, the initial workup will be blood glucose, vitamin B12 level, TSH, anti-nuclear antibody, RPR, hemoglobin A1C, erythrocyte sedimentation rate, complete blood count, and a serum protein electrophoresis. So that was that question. Now let's go to the next one. In this next question, basically this patient is a 46-year-old woman. She went to the ED because she had severe headache accompanied by nausea that was present since she awoke in the morning. And they gave us her blood pressure, which was 176 over 105, okay? So they gave us her labs, which her labs didn't have anything quite special. There was alteration in her kidney function, so creatinine was 2.2, so acute kidney injury going on. And in her urinalysis, also hematuria, so red blood cell count was 10 to 20 per high power frame of red blood cells. So they gave us that information, and the question is, which of the following is the most likely cause of this patient's headache? So I think, okay, there's a headache, blood pressure is very elevated, and there's acute kidney injury. So yeah, high blood pressure can generate the acute kidney injury as target organ damage, and probably this patient is having hypertensive encephalopathy. So there was an option that went with that, which was, of course, a hypertensive encephalopathy. I marked that one, and I didn't think much more about it. But I'm going to read the other options of what could have been going on. Brain metastasis, then you have non-communicating hydrocephalus, subarachnoid hemorrhage, and viral encephalitis. So now that I gave you the other options, I'm going to add a couple very important points into this picture, which made me doubt of answering hypertensive encephalopathy, which was that in physical examination, it said that the patient had bilateral flank masses. So it said the patient had deep abdominal palpation, shows bilateral firm flank masses. So when I read that, I'm like, what could this be? I'm not sure. And things that came to mind, I was like, Wilms tumor? Well, but that would be just on one side, right? Why both sides? And that would be like renal carcinoma, and this isn't the age for this thing. So I just was like, what's going on with these masses? No idea what these masses are. And I also had another thing I read in the questions on the vignette. I had no idea why, which was that the patient had some nuchal rigidity. So it said that the patient had severe headache, and also on physical examination, let's see, somewhere it said lethargic with mild neck stiffness, okay? I didn't make much about it. I just was on the fence. I said, okay, this is probably hypertensive encephalopathy. But remember, in these questions, nothing is there just because, right? Everything in these questions has been very well thought out. So everything has a purpose. So if you can't add things into or factor things into the why this, why that, probably in the end, almost toss a coin between the two options that you have left, which yeah, that's probably, well, if you don't have to toss the coin perfect, but you understand my point. My point is that probably you don't have, at that moment in time, the medical knowledge to understand what is going on. So I just went with hypertensive encephalopathy, but it wasn't that. So the answer was subarachnoid hemorrhage. Okay, now why subarachnoid hemorrhage? Because yes, subarachnoid hemorrhage can generate headache. It can generate the neck stiffness. Why? Because of meningeal irritation due to the blood in the subarachnoid space. Okay. Can it explain the high blood pressure? Well, no, it's going to be a secondary effect of it. So why? Because there was an anatomical abnormality which was worsened off by the hypertension and resulted into subarachnoid hemorrhage. And what was going on? Well, what was going on is explained by the abdominal bilateral flank masses, which were autosomal dominant polycystic disease. So there you have the ADPKD, or big cysts in both kidneys. That's why the masses. That is associated with also the acute kidney injury or the chronic kidney disease. And that is associated in 20% of cases with an aneurysm in your Willis polygon or circulation system in the brain, which that aneurysm is prone to rupture if high blood pressure is going on, which was the case. So that was what happened there. Why wasn't it hypertensive encephalopathy? Because of course we have a best answer. The best answer, which explains everything, was that one. Could this be actually hypertensive encephalopathy? Maybe, but you wouldn't be able to explain why the patient had the masses there, probably, and why the neck stiffness. So that was the pearl. Let's see what else it says. Okay, that was about it. When you have these patients with autosomal dominant polycystic disease, you want to diagnose or you want to screen this patient for aneurysms. Not always. Screening is controversial. So if you choose to screen patients with ADPKD, go and do an MRI. And the MRI is called time of flight magnetic resonance angiography, which does not use a gadolinium contrast. So that's good because it's not going to affect the kidney and it's going to work well to screen this patient. So yeah, that's it with that question. Let's move on to the next one. The next question. Okay, this other question was a patient that had diabetes. Not any diabetes. The patient was in diabetic ketoacidosis. So the patient is a type 1 diabetic and came into the hospital with a glucose into the 400s, and potassium was 3.8 initially. Bicarb was pretty low, so you would expect that in ketoacidosis. It was 13. The anion gap was elevated. There were ketones present. So yeah, DKA. What they're telling you is that the patient was started on IV fluids. So the patient was initially started on fluids and insulin. In the first 2 hours, the patient received 2 liters of isotonic saline, and it was later changed to half normal saline with potassium chloride at a rate of 250 cc per hour. The patient also was receiving the IV insulin infusion. So her glucose came down from 437 to 188 milligrams per deciliter after 6 hours of treatment. So what they're asking you is, which of the following is the most appropriate fluid management for this patient? So they're showing you 2 columns. One is at presentation and 6 hours after treatment. I got this question incorrect because I wasn't able to factor in maybe an important point, which was that mainly the potassium level. So I saw that the potassium level initially was 3.8, and at 6 hours post-treatment, it was 4.8. So I'm thinking to myself, okay, it's 4.8, and we are still given potassium supplementation. And my reasoning is below 4.5, no, above 4.5, we don't have to give any more potassium. So I stopped the potassium. So I chose an option that said without potassium chloride. So that was incorrect because I do know that up to date might say some information similar to this, but in general for the test, potassium above, let's see, if the potassium is below 5.3, give potassium while your patient is being treated for diabetic ketoacidosis. Once the potassium is above 5.3 or 5.3, you can stop the potassium supplementation. That's the main point there. The other, let's see, yeah, equal to or above 5.3. The other important point that you have to take into consideration is that once the sugar level is between 200 and 250, you should add dextrose. So you should probably add D5W to the half normal saline. And what else can we say here? Yeah, that's about it. So that's the main point. I just assumed that the potassium was already enough for us to stop the potassium supplementation, and that was incorrect. Okay, and let's go on to the next question. This next question, oh yeah, I also got this one incorrect because this patient is a 43-year-old woman, has weakness and pain in her left hand for the past 3 weeks, no other complaints, and her medical problems include left-sided breast cancer, for which she underwent lumpectomy and radiation therapy 1 year ago. And this is what's up on examination. So no edema of the left arm, but pain to palpation of the medial forearm and hand. So she has weakness throughout the muscles of her left hand compared to muscles of her right hand. And she also has a couple more things. So it's not only the hand, it's also her pupils are asymmetric. So that's anisocoria. So her right pupil is 4 millimeters, her left pupil is 3 millimeters. So she has meiosis on the side of her symptoms of the arm. And she also has mild ptosis on the affected side. So ptosis, meiosis, and has also these other symptoms in the setting of her having the lumpectomy and radiation therapy for breast cancer on the left. So which of the following is the most likely diagnosis? So I'll give you the options. Option A is brachial plexopathy related to previous radiation therapy. B is brachial plexopathy related to cancer invasion. C is carpal tunnel syndrome. D is cervical spinal cord compression. And E is complex regional pain syndrome. So of these options that I just told you, I crossed out basically all of them except two. So I crossed out carpal tunnel syndrome. Why? Because carpal tunnel syndrome, you just have symptoms here. You shouldn't be having anything in the eye or so out of the picture. I also crossed out cervical spinal cord compression because you're not having cervical spinal cord. Yeah, you're not having any other symptoms. Yes, that would give you a whole lot of symptoms, but why? Like, what would explain it? The question stem does not explain any reason for this, right? Complex regional pain syndrome, out of the picture because no, we're seeing some things that might be associated to this, and it's not only pain, there's also motor symptoms, there's also pupillary findings, so this isn't complex regional pain syndrome. So the two options I was only leaving is brachial plexopathy. That makes sense because brachial plexus is being affected. But why? Secondary to what? So most people answered this question incorrectly with myself. So 45% of us answered it was related to the previous radiation therapy. That was not the answer. The answer was related to cancer invasion. Okay, now let's see why. So brachial plexopathy can occur in patients with a history of cancer and radiation therapy. Cancer-induced brachial plexopathy usually presents with more severe pain at symptom onset, involves the lower plexus, and is associated with Horner syndrome. So remember, Horner syndrome is ptosis, meiosis, and hydrosis. So they gave us 2 out of the 3. So we were suspecting Horner syndrome, but why wasn't it decompression due to the radiation? Let's see why not. So it wasn't option A, or due to radiation, because the patient's lower plexus pain and Horner syndrome suggest cancer-induced rather than radiation-induced plexopathy. So it didn't say much. Okay, let's see. That's just something we have to learn. It says direct cancer invasion of the plexus nerves usually presents with more severe pain at symptom onset, involves the lower plexus, and is associated with Horner syndrome. Radiation injury presents with pain later in the symptom course, affects the upper plexus, and has more paresthesias and weakness. So that's the main reason. It's not an easy one, so that's one of those questions you just have to memorize. Probably understanding why is important, but we probably won't get to that today. Let's just focus on this table that says, yeah, we already know what would be cancer involvement, and we already explained what are the characteristics of radiation involvement, and that's it. I would like to go and read why one would present one way, one would present the other way, but that's the main things to learn there. So those are the ones I got incorrect. Now we're gonna focus on the ones I got correct. Just a couple pearls. We'll go quicker through these other ones. And okay, so this one I got correct, but it was more ruled out sort of thing. I wasn't 100% certain because look at this. It's interesting. It's a patient that is type 2 diabetic, has had diabetes for 12 years. Her glycemic control has been deteriorating over the last few years, despite good adherence to oral medications and dietary recommendations. The patient walks enough. The patient follows a diet, balanced meals. So you could say this patient is doing lifestyle modifications. And patient initially was started treatment when A1C was 10.5%, and medications are glargine, metformin, and atorvastatin. She reports symptomatic hypoglycemia when she skips a meal, and basically they're giving us the labs for today. They're telling us that her A1C today is 8.1%, that her average 30-day fasting glucose is 112, and they're asking us what is the most appropriate next step in management of this patient. So options are A, check 2-hour post-meal glucose levels. B, continue current treatment, reinforce lifestyle changes. C, increase glargine dose by 10%. D, obtain hemoglobin electrophoresis. And E, obtain fructosamine level. So after going through these questions, I ruled out most of them. For example, continue current treatment, reinforce lifestyle changes. That's not the answer because this A1C is 8.1%. We have to do something else. We're not at goal, and the patient is already following lifestyle changes. If they said this patient was not walking, this patient was not following any diet, that would probably be the answer, but not in this case. Then they tell us increase glargine by 10%. That's not the answer because she is telling us that if she skips a meal, she's having hypoglycemia. So it's not going to be insulin. More insulin isn't going to be the answer there. Hemoglobin electrophoresis is not going to be the answer because it just doesn't make any sense. This patient is not anemic, so normal hemoglobin. Obtain serum fructosamine level. I'm like, I don't even remember right now. I think fructosamine level, you would do it when you didn't confide in the A1C because of X, Y, or Z, I think. Yeah, so we ruled it out as well. And in the end, I'm left with check 2-hour post-meal glucose level. But I wasn't sure why, because put yourself in the clinic. You're in clinic. When have you ordered a 2-hour post-meal glucose level? Like almost never, right? And we have these patients all the time. Why aren't we ordering it? Because it usually doesn't make sense. We're not thinking exactly how this. So let's see what's going on. But in this case, it is the right answer because it's something that's not invasive. It's not going to generate any side effects. And you also have that the A1C is close to normal. The average sugar is okay, about 1. I think it was like 112. So all that was okay. So what I was thinking, this patient might be making spikes of sugars after eating. And that's what might be rising the A1C. So let's see what the answer says. Educational objective. A1C is influenced by both fasting and postprandial glucose concentrations. Very high hemoglobin A1C levels, example more than 10%, are usually associated with significant hyperglycemia throughout the day. Whereas lesser abnormalities are often due primarily to elevations in only postprandial glucose levels. If A1C is elevated but fasting glucose is well controlled, post-meal glucose levels should be measured. Okay, so that's the reason, and that's what we had to do. Yeah, I think that explains it. So what is an alternative to the 2-hour post-meal glucose level? It would have been a continuous glucose monitoring device that could have been implemented. That's going to be something that's going to be more and more in the know and more used as time passes. So if you're seeing this video 2025, probably not yet, but maybe in 1 year or two, this is going to be the right answer. Is going to be a CGM, continuous glucose monitoring, right? Because that's already in the works and is already being sort of approved. So now let's go on to the next one. This other one was a patient with rhinorrhea. So what was the right answer? Whenever you have intranasal corticosteroid, that's usually going to be the right answer. In a patient with allergies, almost always, it's tough to beat that one, right? So it says this patient has vasomotor rhinitis, which I also have. It occurs commonly in women after age 20 with perennial symptoms and lack of atopic symptoms, no nasal or eye itching. Intranasal corticosteroids are the preferred treatment. In severe cases, combined nasal corticosteroids and nasal antihistamines are effective in providing symptom relief. Okay. Next question. This one was also interesting because this patient, 62-year-old male, that came in with some abdominal pain, and a specific abdominal pain. Patient had an EKG performed showing ST elevation in leads V1 like through V4 or V5. V6 was normal, but there was reciprocal depression in leads 2 or leads 3 and AVF. So this wasn't pericarditis, right? Pericarditis would be elevation of all of them. So that rules out some things. The troponin was normal. Creatine kinase was normal, but I was like, no, this is too risky. You have to catheterize. You have to do a coronary angio on this patient. And then if all is normal, think of other differentials. But yes, it is extremely rare to have a STEMI with normal troponins, but basically that's what was happening here, and it better be safe than sorry. Even in real life, you're going to do a cath on these patients, even with high sensitivity troponins, unless you have a very, very clear alternative diagnosis. Not in this case. So what's the learning point here? Primary percutaneous coronary intervention is recommended emergently for acute ST segment elevation myocardial infarction. All such patients referred for emergency PCI should be pre-treated with antiplatelet and anticoagulant therapy as soon as possible. Let's see if they mention anything about the troponins. Okay, so it was a left anterior descending artery that was affected. Most appropriate next step is the coronary intervention. They're telling us about what else? Recommend primary PCI for patients with STEMI as follows: within 12 hours of symptom onset and within 90 minutes of first medical contact to device time at a PCI capable facility, okay, 90 minutes, or within 120 minutes from first medical contact to device time at a non-PCI capable facility. So this is to allow for transport to a PCI capable facility. Okay, so that was it. Okay, let's go on to the next question. Got this one correct. This other patient, 39-year-old female, they're telling you that the patient had a left-sided breast cancer. We had mastectomy 2 weeks ago, and now is having tachycardia. And let's see what else. Chest X-ray, unremarkable. But she's short of breath with tachycardia with breast cancer, which was intervened. So they're asking us which of the following is the most appropriate diagnostic approach. And based on the options, you see that all the options are telling you studies that are to assess for pulmonary embolism or lower extremity deep vein thrombosis. So this patient would have a high likelihood, a Wells score for PE, which is high likelihood. So you have to waste no time doing lower extremity compression ultrasonography. So that's ruled out. A ventilation perfusion scan is just something you will do in patients that are, let's see, what was it? I think pregnant patients that you don't want to expose to the contrast. And who else? And or anyone that, or if they have a contraindication to the gold standard, which is CT pulmonary angiography, you could consider ventilation perfusion, but you know that the sensitivity and specificity will go down. So I crossed that out, and I am left with two options. So one option was CT pulmonary angiography after pretreatment with glucocorticoids and antihistamines. That was one option. The other option was CT pulmonary angiography without specific precautions. So the only thing that made me hesitate between these two options or think about it is that the patient has a history of hives after eating seafood. So then I thought to myself, how many times have I inquired about seafood specifically? And if they've had seafood allergy, have I actually done the hydrocortisone and this and that? I'm like, no, no. So probably the answer is CT pulmonary angiography without specific precautions. That was the right answer. Seafood allergy does not confer any increased risk of anaphylaxis from iodinated contrast media and does not necessitate pretreatment with glucocorticoids and antihistamines. So, perfect. That was the answer. Okay. And what else do we have here? That's about it. So I'm reading here that ventilation perfusion scanning, as I mentioned, is if you have contraindication to CTPA, and the options, the reasons they mention here are renal insufficiency or true contrast allergy, or in those with an inconclusive CTPA. Okay, didn't mention pregnancy. I think in pregnancy you did that, but let me know in the comment section below what you would do in a patient with concern for PE that is pregnant. I think ventilation perfusion is the answer, but just correct me if I'm wrong. And let's go on to the next one. So now we're going to go to this other patient. Okay, they're showing us a patient with a scaly rash on the face. They're telling us the patient has a scaly rash on the face, and the patient already received symptomatic therapy with corticosteroids and antifungals. It still persists. And the question is, what is your next step in management for the patient? So they're basically giving you different options. One is anti-nuclear, well, option A, anti-nuclear antibody testing. Option B, HIV testing. Option C, metronidazole gel. D, syphilis testing. And E, topical vitamin D analog. So I was between two options, and let's see. I was between anti-nuclear antibody testing and HIV testing. So the correct answer, well, I'll tell you why. Because I saw the rash. It looked a little bit as if it was lupus, right? Malar rash. But the scaling doesn't have anything to do with lupus. That's not the rash in lupus. So I'm like, no, this isn't that. This is probably dermatomyositis. And when you have dermatomyositis, all of a sudden you have to rule out that the patient doesn't have HIV because HIV might be associated. So that's how I thought about it, and I got it correct. Let's see if it wasn't dermatomyositis, so it was seborrheic dermatitis. But I got it correct either way, so that's always good. Seborrheic dermatitis that is severe and extensive should prompt testing for HIV. In this patient population, it can involve unusual sites such as extremities, and is often resistant to commonly prescribed therapy. Treatment includes antifungals and corticosteroids, often for a prolonged period. So that was the answer, and I think not much to talk about that. Let's see. Okay, now I'm seeing classic systemic lupus erythematosus. Erythema, it does say that there is scaling. There is erythema and scaling over the cheeks and bridge of the nose with sparing of the nasolabial folds. Some patients develop discoid lesions that appear as photosensitive erythematous and well-defined and heal to cause hair loss, skin atrophy, deep scarring, and peripheral hyperpigmentation. So just because the nasolabial folds were affected, it wasn't lupus. That's crazy. This patient did have the nasolabial folds affected, so it was not lupus. And there's rosacea here and secondary syphilis. We will see that in a while. So let's go on to the next question. We got correct, which this other question is acute intermittent porphyria. So it says patients presenting with acute recurrent. These flies, I hate them. Let's get them. Got it. I'm becoming a pro in this. Hopefully our next apartment isn't next to a dumpster. No, it's a nice apartment. This is a good apartment. Very small apartment, very small. But it is what it is, right? The grind. The battle royale. No, it is. We have to keep on grinding, and hopefully we'll have nicer things. But let's keep on grinding, okay? The goal is to enjoy the process. That's the main thing. Okay, so now let's go back to this question. This question was acute intermittent porphyria. So let's just see the educational objective. Patients presenting with recurrent acute abdominal pain combined with dark urine and hyponatremia should be evaluated for acute intermittent porphyria. The diagnostic test for an elevated urinary porphobilinogen during an acute attack. Okay, the diagnostic test is an elevated urinary porphobilinogen during an attack. Treatment involves glucose loading and intravenous hemine. Okay, how often have you seen acute intermittent porphyria? Not that often, right? So yeah, I see this question over and over in these question banks and first aid and step one, and you sort of never end up like memorizing all these details, because I've never seen acute intermittent porphyria that I can recall, maybe, or maybe it wasn't so. Yeah, I would remember. I would probably not remember porphyria cutánea tarda, even if I saw it, because after you see it, it's just the patient that has these, this rash on the body, and it's not the big thing. It's just like the chronic rash, and that's about it. But acute intermittent porphyria, if you see one of these patients, you'll probably remember them because they have this horrible pain, and they have the urine that turns darkish, and the abdominal pain, often with constipation, autonomic dysfunction. So you might have ileus and urinary retention. We mentioned dark or reddish urine, peripheral neuropathy, such as painful flaccid paralysis, hyponatremia, and neuropsychiatric manifestations. So they would be very memorable patients. Okay, let's go on to the next patient. This other patient has malacesia furfur. I just see it, and yeah, that's the people who doesn't have much comorbidities, has this rash on the trunk here, there. They sunbathe, they put on the oily lotion. So that's tinea versicolor, is a superficial yeast infection that can present as hypopigmented or hyperpigmented or erythematous macules and patches. Lesions are frequently seen on oily areas of the skin, such as the chest, back, upper arms, neck, or intertriginous areas. Diagnosis established by KOH preparation of skin scraping. Treatment for limited disease is topical antifungal agent. Systemic therapy is indicated if patients have widespread disease, recurrent tinea versicolor, or those who have failed topical therapy. Let's go on to one of the last questions. This other patient, basically 51-year-old female who just got chemotherapy, who has febrile neutropenia, and they're asking us which is the best initial therapy for this patient. They're giving us different antibiotics. So option A is piperacillin, tazobactam, and caspofungin. Option B is just piperacillin, tazobactam. Option C is vancomycin, amphotericin, acyclovir. D is vancomycin and ceftriaxone, and option E is vancomycin only. So yeah, febrile neutropenia, you want to do gram-negative coverage. It's going to be piperacillin, tazobactam, or cefepime. Up to date, I think we'll go more with cefepime a little more. So yeah, that's about it. Unless you have any risk factors that you're like, well, maybe this patient also has MRSA, this and that. This patient didn't, so it was just piperacillin, tazobactam. And educational objective says neutropenic fever should generally receive monotherapy with an anti-cetomonal beta-lactam agent, piperacillin, tazobactam. The routine addition of vancomycin targeting MRSA is not recommended due to increased risk of complications unless certain criteria are met. So I wrote this question basically, right? I explained it pretty darn good. So let's go on to the next one. So I'm like a combination between a little bit tired and woken up, right? So it is what it is. You guys know it. If you're seeing this video, you will relate. So this other patient, 44-year-old male with the HIV infection. This patient has not been on antiretroviral therapy because patient is non-adherent. CD4 count is 6 months ago was 90. And on CT scan of the chest and abdomen, there was lucencies in the skeleton and bulky mediastinal and abdominal lymphadenopathy. So bone marrow biopsy in this patient would most likely show which of the following. So option A, chronic lymphocytic leukemia, B, fungal infection, C, Kaposi sarcoma, D, multiple myeloma, and E, non-Hodgkin lymphoma. So yeah, the answer, I was between Kaposi and non-Hodgkin, but it wasn't telling me any of the skin rash with Kaposi, so it wasn't Kaposi. And non-Hodgkin lymphoma, yes, these patients with HIV, just HIV is a risk factor for lymphomas, and untreated or non-adherent patients, even worse. So AIDS-related lymphomas are common in patients with advanced HIV, a low CD4 count less than 100, high HIV viral load, and a prior diagnosis of AIDS. Okay, that's basically risk factors, right? Patients with non-Hodgkin lymphoma tend to present with B symptoms, extranodal disease, and involvement of unusual locations. Diffuse large cell non-Hodgkin lymphoma and Burkitt lymphoma are the most common AIDS-related lymphomas. And last question here to give you a break is this 21-year-old woman came in for a sleep and appetite disturbance, and they're asking us which is the most likely diagnosis. So they're telling us that this patient basically binges. So she binges, she eats a whole lot, but not only binges. So in addition to eating the whole bucket of ice cream here and there, she also does something compensatory mechanism to the binging, which is not vomiting, but using laxatives. Okay, so that is telling you this isn't only binge eating disorder. The patient is also doing something else, which is doing this, the compensation, the laxative. So that's now between bulimia nervosa and anorexia nervosa. How do you differentiate bulimia from anorexia nervosa? The difference is the BMI. Normal BMI, it's going to be bulimia. Decreased BMI, I think below 18.5 is going to be anorexia nervosa. So in this patient, the answer is bulimia nervosa. And the educational objective says bulimia nervosa is characterized by excessive preoccupation with weight and recurrent episodes of binge eating and compensatory behaviors that include self-induced vomiting, laxative abuse, fasting, and excessive exercise. Patients are normal to overweight in contrast to the low weight seen in the patients with anorexia nervosa. And remember the treatment, this might be a question they might ask you regarding bulimia nervosa. Treatment is going to be, cognitive behavioral therapy will be the mainstay for all these eating disorders. But medications, here's where they can trick you. Bulimia nervosa and binge eating disorder, SSRIs, okay, that's going to be the answer. But the main difference is anorexia nervosa. The main medication is not an SSRI. You don't choose SSRI in anorexia nervosa. You choose in a typical antipsychotic, which is olanzapine, okay? So that's the main thing. And that's it for today, and I'll see you in the next episode. Hope you liked it. Give me any feedback. Tell me what I didn't do correctly. Give me, everything is for growth. So you can drop a like. You can do whatever you wish. See you later. I'm going to walk the dogs.